Most of what you're going to see, dermatologists never see. Dermatologists like to see complicated things, mostly cancer. So you are likely to see any cancer drug. Everything else that you see is seen by people other than dermatologists. And they come in three categories. Benign disease, bad disease that you better figure out, and complicated disease. Things that are a visual representation of something bad going on inside. So we'll start real simple. All right. So this is what we're going to do. If we get to the HIV dermatology, fine enough, we can do it some other time. HIV disease has its own whole world of dermatology, totally unrelated to what you would see in immunocompetent people. Okay? So, we're going to look at pediatric infections, we're going to look at non-infectious dermatology conditions, and we're going to look at the most important things, which are the cutaneous manifestations of systemic diseases. A really mean condition of, you guys better finish eating.
I was just going to say, there's your candidate, Jack.
I think you better see somebody about that.
Yeah?
That's what I would say.
What are they?
Warts. Warts.
Warts. What causes warts?
Virus.
What kind of virus?
HPV.
That one.
All right. 66 types, commonly sexually transmitted. Okay? Non-sexual transmission in children is common, so whenever you see a kid with genital warts, don't immediately assume that this is a child molestation case. Okay? Obviously type 16, 18 have something to do with cervical cancer. Okay? They're very common in renal transplant patients because they're immunocompromised. Okay? Standard treatment that was advocated before is interferon. Interferon doesn't really work. Doesn't matter what you do, whether you fry them, freeze them, cut them out, and so forth. Just be careful what you're using. I like to use trichloroacetic acid and bichloroacetic acid in non-facial areas. It works very well, penetrates, may take more than 1 or 2 applications. Spanish fly cantharidin doesn't work that well. Okay. Just an itching agent. All right. The largest virus known to man. It's a greasy old big fat virus. You see it predominantly in 2 populations, immunocompromised people and kids under the age of 2. And some of these kids are pariahs. They go to school and they're covered with these and nobody wants to touch them and everybody wants to stay away from them. Chicken? No. They may last a couple of years. Okay, this is molluscum contagiosum. Characterized by a small umbilicated lesion like that. Molluscum contagiosum is the largest virus known to man. It's covered in this big greasy ball, and because these kids have never seen it, they can't develop immunity because the virus is protected. And there are all kinds of treatments suggested. Sand them down, hit them, irritate them, burn them. The best thing you can do is do nothing, because eventually, suddenly, one day, the kid will wake up and it will all be gone. Okay?
Yeah.
Next. So this is molluscum. It's a large virus, okay? The lesions are, they can be small, they can be large, anywhere from 2 to 10 millimeters. And the characteristic histological features, they are samoma bodies. Okay, nobody ever looks for them, but that's kind of what they are, okay? You see it predominantly in these two populations, kids and immunosuppressed people. Next. Okay, vesicles in a very discrete area. Think simple. Next slide.
Chicken pox, maybe.
This is plain old herpes simplex. You can't really tell herpes simplex from 1 from 2. And it doesn't necessarily have to be in the genital area versus an oral area. Okay? 20% of all genital infections are due to HSV1, okay, as opposed to HSV2, so they can cross, okay? In people that are who are naive to herpes virus, their primary infection is a systemic infection, which would be an infection with very high fever, and it's a rash, And these people look really toxic, okay? Most people have been exposed to HSV 1 or 2 from early childhood, so they just have recurrent aphthous ulcers or breakouts in the lips or in the back of their throat. This is a tongue, okay? The tip of a tongue, okay? Very, very tender. You've all had these.
Canker sore?
Cold sore.
Right. Next slide. Okay. So these is aphthous ulcers. Aphthous ulcers are different from herpes ulcers. We believe they're also virus initiated. Okay. And here's one of those things. When you see these people with recurrent aphthous ulcers and they stay all the time, think of a bunch of other things that it might be. Scurvy, vitamin C deficiency, is one of the common causes of aphthous ulcers in third world countries. Okay, lichen planus is something we see a lot in the adult population in the United States. I'll show you some more pictures of lichen planus, but it's characterized by genital and tongue ulcers. Okay, last one to remember is gluten-sensitive enteropathy. People that are sensitive to wheat who basically can't tolerate gluten. One of the forgotten treatments for this is colchicine. You guys know the story about colchicine? Colchicine is the oldest drug known to man. It's over 4,000 years old. Okay. It comes from colcha, which is a plant. So, about a year ago, a company did some studies on colchicine to demonstrate what the actual safety criteria for colchicine was, which then threw out all of the data from previous use of colchicine. Colchicine is one of these orphan drugs that got passed on. So colchicine, which used to cost a penny a pill, now costs $6 a pill. So it's called Colchris, okay? And it's now branded, and for the next whatever number of years, the company that makes it, okay, has total control of the market. It's the biggest colchicine is a standard drug for gout.
Is that also used to suppress cell membrane division?
Correct.
Okay.
Correct. And this is why it works in a lot of these. But it's a forgotten treatment. And colchicine, like I said, used to be cheap. Next. The trick to remember is it's circumscribed. It starts at the middle of the back and it runs down. And it's only on one side. And it's painful.
Shingles.
Yeah, correct.
That's a shingles.
That's what it is.
Yeah, it's big.
Shingles. Okay, and you all should have your shingles vaccination soon. All right, next one. Okay. Shingles is seen a lot in HIV patients and in patients with malignancies that have been treated with immunosuppressive agents. Okay. Most important thing, if you have a lesion on the nose, you better look at the eye. Okay, because you're going to have corneal shingles, and that's really bad. The use of corticosteroids is questionable. It seems to be that it actually helps. But the standard treatment is high-dose acyclovir and corticosteroids to avoid postherpetic neuralgia, which is one of the worst things that a patient can have because it's almost lifelong. Okay? It's basically paresthesias into the nerve distribution where they had the original shingles, and these people are in constant pain. Next. All I can tell you is that you better ask all the right questions to these patients. And this is an individual that works in a meat market, in a large meat market in a packing plant, okay? And works exclusively with lamb. This is one of those things where you kind of need to know, and it's not painful. Next slide. This is ecthema contagiosum. It's caused by virus. Okay, it's seen predominantly in vets and farmers and people who work with sheep. Okay, so don't confuse it with things that could be bad. Compared to next slide. This in the right setting, which is a nursing home in a patient that has been in bed for a long time, where nobody ever uncovers the patient and looks at their skin, okay, they get this. And if they're unlucky enough, they will die from this within about 24, 48 hours.
Wow.
Next. This is edema gangrenosum, okay. It's an endotoxin from Pseudomonas, okay. And oftentimes when you see a patient that was in the nursing home and dies, and quotes died of natural causes, okay, and the pathologist says died of natural causes, we don't need a post, so nothing happens. Nobody ever looks at the patient's covered in these really bad ulcers, okay, and that's what they die from. They die of septicemia.
Is that's different than a pressure ulcer, or no?
Oh yeah, totally.
Totally.
Different.
Okay.
Nothing to do with
nothing to
pressure
do with that.
No.
Not exacerbated by it, or
None of these people die within 24, 48 hours.
that quick. Wow.
It's just
Is it preventable?
It's fulminant.
It goes systemic and then we die.
Yeah, basically what happens is you get a septicemia from it. The virus produces, the bacteria produces a huge amount of toxin, okay? You go into cardiac failure, basically shock. Next.
Is that what they call gangrene?
No, no. It's
Is
not
that-
gangrene.
that's
Gangrene is rotting, okay? Tissue that has no oxygen because it rots. This is septic shock.
So there is a treatment for that?
If you catch it long enough, antibiotics. This is fungus. Next slide. More fungus.
They may not want to tell you.
Okay, so this is Candida. Okay, plain old Candida. You see a lot. Oops. Go back.
Did you want to, okay.
Go to the
Yep.
there. Okay. Obviously, Candida can be multidimensional. Okay, some women are all contraceptives, certain antibiotics, and geriatric patients and nursing homes. And I found a lot about nursing homes because this is a huge source of contamination. And if you look at the primary source of why we have so much MRSA, MRSA preceded this community MRSA by about 10 years. We've had MRSA in the nursing homes for about 10, 15 years. Okay? And now it's kind of gradually spread into the community. But the reservoir is in the nursing homes. Next. So, you have a person comes in and, oh yeah, it's Candida, right? And they don't get better. And you treat them again, and they still don't get better. So there is this little bug called Corynebacterium minutissimum, next, which basically looks exactly like Candida, all right, but doesn't respond. It's basically bacteria. Next. And basically it looks exactly like Candida albicans, whichever fungus you want. But the treatment is an antibiotic and not an antifungal. So things could fool you. So, you know, whenever you treat a patient, there's no penalty for treating them initially as a fungal infection, but then if you don't, you know, get any results, think about other things. You know, don't just say, oh shit, go to the dermatologist. Dermatologists never see Corynebacterium minutissimum, ever. They pass it, you know, their boards, and they was on the boards, but they'll never see it. Next. So, here are areas of depigmentation. Little white spots. Next. Areas of hyperpigmentation. Next. And areas of depigmentation. Caused by something called Malassezia furfura. You all have it. It's just that it comes in different intensities. Okay, Malassezia furfura is a virus that basically infects the superficial skin and the deep skin and prevents UV rays from coming through and tanning you. So in summer, when you see people that suddenly have spots or stuff like that, that's what happens. They've got Malassezia furfura. It's harmless, I guess, unless there's a cosmetic value behind it, or you are a model. Okay? Most likely, unless it's really bad, you probably don't need to treat it. Okay? We call it actinium versicolor. Next, okay. This is deep fungus. We have to separate superficial fungus from deep fungus. Superficial fungus might be treated with creams. These guys, in particular in the scalp, they're called perions. Okay, they are impossible to treat. You have to treat them for many, many weeks with fairly high dose antifungals. So,
When you say high
Pedis
dose,
capitis,
Ricardo, when you're talking, are you talking orally or
orally.
orally, like?
Orally. The way antifungals work, they accumulate in the fat in your body, and you can take a 10-day dose, and you will have antifungal medication in your system for about 4 weeks. Okay? This is why you have to be conscious of liver-active processes. Okay? Some are more than others. But fungal nails, everybody eventually gets fungal nails. Okay? There's only one treatment. Okay? That's systemic antifungals. You won't cure them otherwise.
Where does this stuff come from? I mean, I know it's transmitted through the air, but are there precautions you can take to not get these fungi?
Athlete's foot's your classic form.
Right.
Hygiene to some extent has something to do, particularly in the scalp.
Right.
But if you look at all the homeless walking up and down Broadway there, they all have carry-ons, they all are fungated, they all have candida.
Yeah.
Back in the old days, when they came into the emergency room, we had these shower stalls, okay? And there was one attendant that had the responsibility of basically taking all their clothes off, putting them into the burner, and then hosing them down, and then putting, slight suspension of lye on them to basically disinfect them.
Right.
We don't do that anymore. It seems like cruel and unusual punishment.
When I get homeless that need valve surgery, we will go do that.
Under extraordinary circumstances. The point is, we neglect the major sources of contamination in our system. Next. This is bad disease. You see that in a patient that has this brawny edema and high fever. Don't screw around. Okay? And this is a commonly missed thing. Now, here's where your strep test comes in. If you do a quick strep test on this woman's throat, you'll come back positive. Okay? This is something called erysipelas. Next. Erysipelas is the lymphatic spread of strep pyogenes, group A strep. Okay? And instead of going into circulation or remaining in the throat, it actually penetrates into the lymph glands, particularly the neck, okay, and it spreads really badly, and it can be deadly. Next. So, you see this all the time. This is not dangerous, just looks bad. Next. Kind of looks like that nursing home patient, except this is a baby, okay, or a young child. Come on, next.
Impetigo.
Impetigo. Next. Okay, impetigo is no longer sensitive to plain penicillin. Most of strep and staph that we see, okay, has to be treated with other medications like augmentin, erythromycin, and dicloxazole. Okay, so we have evolved. It used to be the dogma that all penicillins work for impetigo. They no longer do. This is the whole process of resistance development. Next. So now, it's Friday night, okay, and you just got home, you get a call from a patient, you go back to the office, you see the patient. The patient has 170-degree fever, okay, cooking like crazy, okay, and has this whole body rash, okay, everywhere, okay, including the hands, okay, spares the inside of the mouth, okay, but it's everywhere on the face, the ears, okay, and the kid's really cooking at 107. Okay? So you ask the kid, so, what you been doing? Okay, well, what's happened? He said, oh, nothing, I just had this, funny thing that, I was dealing with, and went to the health department this morning. They gave me a shot of penicillin.
Is this an allergic reaction to penicillin?
Yeah, how about that? Yeah. Next. Okay, you see one of the palms. Next. This is called the Yadish-Herxheimer reaction. It's fulminant. In the worst of cases, it really is bad. What happens is they get a shot of penicillin, and the penicillin busts up all the bacteria. The bacteria, the treponines, have these antigens, these pyrogenic antigens, and you mount this huge fever, huge reaction to the circulating antigens, which are the busted up treponines, and you can die. You can die. You cannot control the temperature. So, cooling blankets, steroids, respirators, you name it. Okay, kid needs to be in the hospital immediately. It's a bad thing when it happens. And the interesting thing, you know, they do it in the health department all the time. You know, it only happens on secondary syphilis. Okay, it never happens in primary syphilis.
What's the difference?
In tertiary syphilis.
Secondary, primary?
Only secondary when you have the rash and you have the manifestations of the evolution into secondary stage, which usually happens at, you know, about 4 to 6 weeks after you've had the primary stage.
Got it.
Next. Loose silvery lesions on the skin are the most important things that you can find if they're there. 22-year-old young female, sexually active female, feels fine, temperature of 99, okay, comes in for a routine pap smear, okay, and she says, "Yeah, by the way, I've got this thing." I don't expect anybody to really know this. Next slide. This is gonococcemia. Contrary to what most people believe, blood-borne gonococcus does not cause serious infection. Okay? It is basically manifested by joint pain, certain fevers. Most important thing is that if you try to take a culture from the skin, it'll be negative. Okay, so you have to get a blood culture. But if you're smart enough, you know, you're going to do that pap smear. You're also going to do a GCM chlamydia culture, and it'll come back positive. So gonococcemia is the most underreported disease, particularly in females. This is a kid with a very sandy rash. You see him. Next. The next thing you see is that we got a strawberry tongue. Okay. The mother says, yeah, their tongue used to be white and used to really scrub it the last couple of days. Now they have a strawberry tongue. And their skin's desquamating.
Oh, wow.
And smart guy that you are, you get what?
Call you.
You call me? No, smart guy that you are, you go ahead and you get a strep test. This is scarlet fever. Okay. Scarlet fever is the most commonly missed strep infection. Strep infects the kidneys, the skin, the heart. You know, it has a predilection for all kinds of different organs. And this is where you need to kind of, you know, have your level of suspicion. Again, a urinalysis, a strep test, and a syphilis test will very likely keep you out of trouble with some of the things that can be potentially very dangerous. So, next. Another one of those little purple lesions. The reason I intercalate these slides is for the residents. You know, this is like the most common thing people miss, looking at their patients. Next. Again, gonococcemia. Okay, next. Purpuric lesions which happen overnight. Healthy individual who next morning got a fever 106, prostrate, unconscious, and in a coma. Happens on this campus.
Meningitis?
Meningococcemia, next. Okay? Remember, meningococcemia, and we have a vaccine. Okay? The vaccine is effective. Okay? 10% of people that are at risk get vaccinated. Okay? So, kids you send out to college, get them a meningococcus vaccine. Next. Not everything that you see is come and go. These are little vesicles filled with fat. Molluscum contagiosum. Okay, the umbilicated lesions that I showed you before, sometimes they manifest in older people as little vesicles with fat in them. Okay, but they look like that. These poor kids that walk around with that, you know, they're like pariahs. This is a risk for dentists more than anything else. Dentists who don't wear gloves. There's no reason for you to know this. This is something called herpetic whitlow. It's direct inoculation of herpes into the skin. This is a kid, okay? They have a herpes lesion in their mouth, chew, and they inoculate the virus into their skin. Direct inoculation of herpes, and it's very painful. Very, very painful. All right. Dewdrop on a rose petal. That's what this is called. This is the earliest lesion of... Yeah, there you go. Chickenpox. Next. Okay. If you happen to see it, and it is there, you catch it in time. Okay? Remember, chickenpox is not a benign disease. Chickenpox pneumonia, chickenpox cerebritis, can cause really bad illness.
Yeah, I remember I had it a second time when I was older. I was like 16 or 17, and I found one just on my torso and noticed it in the shower and whatever, and the next, maybe 2 days later, boom, everywhere. But there was like a 2-day period between those.
Chickenpox is a dirty rash disease, okay, which has vesicles, has all kinds of different manifestations and stages of the disease. And chickenpox parties are not smart things to do.
Yeah.
Next. So, it's characterized by centripetal rash starting in the periphery and working to the middle. Okay.
What do you mean by a dirty rash?
Dirty rash, it has many stages. There are crusties, it has vesicles, it has new lesions that start as big red, irritated lesions. They're everywhere, but you know they start in the periphery and move inward. So the ones in the periphery dry out, and the new ones appear in the center. Okay, let's go. Okay, there is this whole population of rashes that are seasonal that you see in children. Okay? This is on the hand. Okay? And rashes on the hand come in two varieties. A few of them are benign, most of them are not benign. Next. Okay. This is hand, foot, and mouth disease. Okay. Hand, foot, and mouth disease is caused by Coxsackie A16 mostly. Okay? And as it says, it's
nasty stuff.
His kids got that.
Yeah, it's a nasty
They
disease.
gave it to me when I was an adult. It was not fun.
So the big,
Explains
anytime you see hand and oral lesions, think of bad things, okay? Coxsackie, lichen planus, those kinds of things. Depends on the age, of course.
All these lesions, I mean, look alike. After we
I
find
like
it,
that.
it is easy to...
You've got to ask the right questions. Have to figure out the right setting, the right kind of patient, the right season of the year, what's happening in your community,
age of the patient.
and age of the patient, of course. Yeah. This is called the slack cheek syndrome.
Having child syndrome.
Roseanne.
Correct. Correct. Go. Okay, this is erythema infectiosum, fifth disease, roseola. Okay. It caused by parvovirus B19. It's very, very, very sinister in terms of its effects on fetuses. Okay, it causes essentially heart failure in fetuses. Okay, it causes fetal hydrops. So one of the advice you must give to women at all stages of their pregnancy. So stay away from kids that have rashes. Next.
I do that.
And this kid's really sick, has kind of the same lesions as the Coxsackie. Okay, but this kid has a high fever and basically just visiting family in Ohio.
Lyme disease.
Lyme disease. No?
Lyme disease in Ohio?
Ohio disease.
Lyme, Ohio. Okay, we'll forget that. No contact with wildlife.
Okay.
Go ahead. This is Rocky Mountain spotted fever.
Oh.
Okay? Again, you've got to remember,
I ever saw.
there's a whole population of patients, okay? Bad thing about Rocky Mountain spotted fever is the only way you can truly diagnose it is through the biophilics test, which is only run by certain health departments. Not every health department has the ability to run it. It's a cross-reaction with Proteus OX19 antigens, but it's a really difficult test to get. You know, I mean, if you're on a Saturday, forget it. You know, you just don't know. But in the right setting, you kind of need to think about it. Again, location, age of the patient, what's been going on, what are the symptoms, and what may look like Coxsackie, you know, B19, okay, turns out to be Rocky Mountain spotted fever. All right, now we change tracks. This is kind of a smooth rash, but has all of these target lesions and spread areas of redness, but they're not elevated. Next. This is rubeola, measles. We still have measles around. The problem with measles is that everybody has some sort of partial immunity because they've had a vaccine or maybe come in contact with, you know, partially infected. So it now becomes atypical. So the rashes that you see no longer look like classic measles, they look like who knows what. So, you know, again, do your strep screen, do your urinalysis, make sure you don't have any red cells and protein in the urine, and then, you know, you're probably okay. But, you know, the typical things are no longer typical. The biggest thing to remember is to differentiate it from Kawasaki's. Lympho-cutaneous lymph node syndrome. Okay? Mucocutaneous lymph node syndrome is a disease in most young children under the age of 2.
Chainsaw.
Okay? Where you have fever, unexplained fever, conjunctivitis, and a rash. Okay? Its biggest problem is it causes heart attacks. It basically causes hypertrophy of the coronary vessels and get shut down. Kids have heart attacks.